So welcome, everyone. I'm Dr. Brian Sims. I'm a senior medical advisor with the National Association of State Mental Health Program Directors, but even more so, I am honored to be your host for today's episode of the Crisis Jam. This is episode 142, and it is packed today. So I'm going to move through it fairly quickly. Just want you to see that things are going to be happening here. In the talk.crisisnow.com website, you have all the information that you need to be able to move through. You can see previous episodes. You can go in and take a look at the legislation maps or the toolkits. It is a wealth of information that can give you a lot of upfront as well as past information about things that have gone on in the jam. If you've had any difficulties with the Crisis Jam coming off of your calendar, please make sure that you check in. You can check with Karen on our end. We can see how you can get back onto the calendar. We'll get you straight. Next slide, please. And of course, we always focus on the top 5. Now, if you didn't notice today, I may have gone through it fairly quickly, but our featured presentation today is going to be on Google and technology. And I just want you to see that of the top 5 presentations we've had, one of them was actually a special tech edition. So we're seeing that technology is really important across the realm of our spectrum, but also I would anticipate that today's session is going to be no different. Because if you look at number 4, it actually is there. And as you go through the top 10, you begin to see one thing that becomes evident. All of them are moving upward. The numbers are continuing to rise. People are starting to watch and absorb and begin to move through these crisis jams. So we're really happy with that. So let's go on to the next slide. Okay, in the crisis jam, we have had nearly 400 unique speakers in the 140 some odd episodes. This is really phenomenal information because it really tells you that people are connected. And we still need from you any ideas that you have. Please feel free to put them in the chat box. Let Karen know that this is something that we would like, and we will respond as well. The next slide. And this message comes to you from the U.S. Surgeon General, and he kind of poses a question. What if there's something in our everyday lives that can transform our whole health and well-being? And it's one of our latest advisories. And what he's saying is that that something is called social connection. So I'm going to put links in there so that for this particular site, but it is something you want to go into because the social connection is such a positive and such an important piece of making this whole issue of crisis response a really important piece of what we do. Next slide. Here's another report that talks about no hose, no gun, police alternatives for mental health crises falls short. And really what it is looking at is trying to find out those things that we need to be putting in place, like more funding and more support so that we can keep police out of the primary response that we're seeing going on. So next slide. And now here, I just wanted to point this one out because it's occurring today. We have Dr. Matthew Goldman, who's going to be presenting on selecting crisis system metrics, the who, what, and why to measure and what matters. So we're putting a link in, but just making you aware that it will be happening today. And we move to our SAMHSA store, and this is just a reminder again that SAMHSA has a number of free items that you are able to get that is supportive of continuing the message of 988. And it also is very important now because we're trying to get the message out to all of our communities that 988 is there, it's functional, and that they are connected and services are indeed available. Next slide. And as we go through it, also a reminder about the Crisis Jam store, where we have the t-shirts available. And again, an open invitation to any of you. If you would like to be a crisis hot seat person, please let us know, because you can come on and again, right or wrong, whether the question is you answered right or wrong, you'll get a free t-shirt. And as you can see from the vast array, we have it in English, we have it in Spanish, You can also get different types of long sleeve, short sleeve, and even hats. Now, let's look at again. I love the kind of minion scenario here. 988 is a terrific start for communities. But we also need mobile teams and crisis facilities. So think how 911 needs ambulance and hospital emergency room capacity and quick access. We're kind of putting that connector together. So this is a theme moving forward that as you look at the 5-year vision of SAMHSA, you can see how it's integrated in to take a look at the horizons where we are already, where 90% of all 988 contacts are answered in state already for a lot of the states. As we move now from 2023 going into 2025, we're looking at the horizon number 2 at the mobile crisis services of the someone to respond. And then of course, by 2027, looking at 80% or more of individuals having access to community-based crisis care. So what this is telling us is that we still have work to do. But again, if we add all of this stuff, the naysayers again, won't it be more expensive? 8 states have already passed legislation to fund 988 and more, but hey, what about the rest of them? So again, we're looking at this from the standpoint of where we're headed. So at this point, I would like to call on Courtney Sheehan, the Senior Program Director for CCDHC. Courtney, do we have you on the line?
Hi.
Hello there. Good morning, welcome, and thank you for being our trivia hot seat person for today. So if you are ready, this is going to be kind of a broadened one. So prepare yourself because we're going to be adding a few pieces here that we don't normally put in, and hopefully it'll be helpful. But just with the same rules here, we'll pose the question. You can then use the audience, or you can call a friend, or if you know the answer already, you can simply answer it all on your own. So if you're ready, let's go ahead and get started. In 2020, Dr. Matthew Goldman conducted an analysis of the Arizona Medicaid claims that included over 125,000 crisis service episodes for adults. And he focused on escalation to a higher intensity service within 72 hours, for example, mobile to emergency department, but most did not receive multiple services. So what we're going to do here is initially pose a question, but I'm going to throw you some additional information if that's okay. But the question that's being posed is, which of the following serve the most individuals without other supports? And you see the 4 choices here: mobile crisis only, crisis receiving facility only, hospital emergency department only, or psychiatric inpatient only. So what I want to do is give you a little bit more of a clue, if that would be helpful. So we're going to call on Dr. Matthew Goldman to just give you a quick little clue based on the slide that we have here. So Dr. Goldman.
Hi there, everyone.
Hi there.
So this is a tough question, typical of David Covington. And the main thing to think about here is that what we found was that service settings that were in crisis-only settings made up almost half of all crisis service episodes in the entire state for that year. So there was a skew towards like meaningful, almost half of all episodes being in those mobile crisis or crisis facility only type settings. So that might help narrow it down for you a little bit.
And thank you, Matthew, for that. So Courtney, I don't know if that helped or did not help, but what are your thoughts on this? Would you like to attempt, based on the information, what we're going to do is pose it to the audience. And audience, we would ask that all of you please respond to this so that we can give Courtney all of the help that she may or may not need. So Courtney, what do you think so far?
Well, first of all, I love this question. Not to say I'll get it right, but I love this question because it's data-driven decision-making, and yes. Excited to be here today because we are on the cusp of going 24/7 mobile on Monday. So it's a really, I think I'm considering this a good luck charm of sorts. I'm going to phone my friend. I have Elizabeth Smith here, our clinical program director.
Okay.
I'm leaning towards A, but I'm curious what her brain says, because she's fantastic. Elizabeth, do you have a vote?
Hi, Courtney. Yes, I was also thinking mobile crisis only, as hopefully that's the first stop and it doesn't go to all the other wonderful services.
Yeah, let's do it.
Well, let me ask, before even then, would you like to see what the audience has said?
Absolutely.
Because what we're seeing from the audience is they seem to be leaning in your direction. That over 50% of them are saying A as a response as well, with followed up by C, hospital emergency department, and then lastly with crisis receiving facilities. So with that information, you are locked in at this point?
Sure am.
All righty, and you are going with?
A.
Okay, well, the answer is B. Crisis receiving facility only. And what they've noticed is that over 40% remain in crisis-only settings, but crisis receiving facilities were the strongest driver of the lower costs, shorter stays, and less restrictive care for those in behavioral health emergency, with nearly 35,000 being stabilized in these settings. As you mentioned, tough question, but you get a t-shirt nevertheless. Absolutely love it. And Matthew, if I could turn it back to you for kind of a pull together comment, if you would, sir.
Yeah, happy to. So, I mean, this is a very interesting analysis, and I appreciated your comment there, because it is meant to be evidence-based decision making, and the findings were clear in a system like Arizona's, where there's been meaningful investment in this type of mobile crisis facilities. The diversion idea really can come to fruition, and that's very much what we saw in the Medicaid claims there for at least this population, where there's we see lower costs, we see lower restrictive care, and also shorter stay type settings. And so, important findings here. And I'll add that we also are currently working on a follow-up study that drills even more focused into the post-crisis period to really examine those outcomes. So thank you for the opportunity to talk a little bit about this important work. Thank you.
Well, thank you, Dr. Goldman, and Courtney, thank you so much for your participation in it. I think if you check the chat box, you'll see you've got a tremendous amount of support, and a reminder again about getting in contact with Karen about that free t-shirt. Thank you again for all of your participation. And we're going to move to the next slide. That is really a quote. And I'm going to call on Tom to just get a comment on this particular quote.
Thanks, Brian. And really just this builds out of a conversation we were just having around the data and what it shows. And I was the Medicaid director in Arizona, fortunate to be during this time frame. So really appreciate seeing this analysis sort of after the fact, but we're always looking for levers by which to invest. And those best investments really are the opportunities to drive better outcomes for the populations that we serve and balance that with something that looks at ROI. And I think the data around crisis is unique in that we're starting to see a strong basis of the types of saving opportunities that exist in terms of being able to channel and direct services towards improving outcomes, but also reducing costs. And the data that's out there doesn't even include other system costs like the justice system, where we know we're driving savings as well by creating different pathways in to be able to serve individuals. So it's great to see the data. Data helps inform our decision making, but as Medicaid leaders, we're always looking for levers to be able to drive better outcomes and reduce our costs. And that's what's so exciting about the work in crisis, is it gives us that opportunity. So thanks, Brian, to sort of highlight the quote here and to talk about the opportunities for Medicaid to invest in crisis services.
No, indeed, it is a pleasure, because again, I think we've heard it already that so much of this is so data driven that it's very important to bring these particular pieces out. So thank you for providing that support and being there for it. Unfortunately, Tom, we don't have a t-shirt for you, but we'll work on something else for you.
That's all right. I'll keep bothering David.
Okay. And with the Crisis Jam, we are getting ready for our feature presentation for today. With the Crisis Jam, connect with people you trust. And I absolutely love that particular connector. We have today on our Crisis Jam several speakers, and it's mental health resources from Google and the International Association for Suicide Prevention. We have Dr. Renee Schneider and Dr. Rory O'Connor. And I'm going to ask them to just briefly introduce themselves, and then please proceed with today's feature presentation. So Dr. Schneider, if you want to go first, please.
Thanks, Brian. So my name is Renee Schneider. I'm a licensed clinical psychologist, and I reside and work in the San Francisco Bay Area. I'm the lead in the Mental Health Center of Excellence at Google, and I'm also a DBT trained therapist. So I'm very interested in supporting people with, particularly with chronic suicidality and self-harm. And I will turn it over to Rory.
Thanks, Renee, and thanks, Brian, for the invitation. It's my first time at the Crisis Jam, and I just love the vibe. It's just so supportive, so engaging, and really, really enlightening. So thanks for the invitation, and for all of those who are attending. Well, hopefully we'll find our brief presentation of interest. So I'm Rory O'Connor, and I'm Professor of Health Psychology at the University of Glasgow, where I lead the Suicidal Behaviour Research Lab here in Scotland. But I'm also President of the International Association for Suicide Prevention. And really, it's in that capacity, broadly speaking, that we'll be talking today with this really exciting collaborative project we've been working with our colleagues at Google on. And I've been doing work on suicide research. I'm a psychologist for about coming up 28, 29 years. And I suppose what we'll focus on a bit today is trying to translate some of that knowledge of what it feels like to be in a suicidal crisis into the work that we've done with Google. So on that note, I'll hand back to Renee, and Renee's going to be leading most of the presentation, and I'll come back and add my tuppence worth in a few minutes' time.
It's a collaborative effort. So, okay, we can go to the next slide. So at Google, Google Search, we're really interested in helping people kind of all along the spectrum of mental health. And if you look at this slide, you can see there are a lot of users who come to us looking for general information on symptoms. Maybe they're looking for assessment tools. Then there's another subset of people who come who are in distress, and they're looking for maybe resources like apps or podcasts or even therapists. And then there's a smaller subset of users who are in crisis. So they may be putting in a query related to suicide. And those are the users that we're going to talk about today. So we can go on to the next slide. So right now on Google Search, and some of you may have seen this, we advertise or have the 988 number front and center at the top of the page for people who put in a query related to suicide. We also, interestingly, have hotlines available for sexual assault and domestic violence worldwide. But of course, today we're talking about the 988 number. So our goal is really to connect users with the help that they need in their moment of need. Next slide. So even though we know that this hotline number is saving lives, we hear stories all the time about how somebody reached out on Google and then they got connected to 988 and it saved their life. We also recognize that not everyone is ready to call 988. And so we wanted to think about what other features we could use to enhance this experience. What are other ways that people could connect with someone they trust, with a loved one? And that's where our coping module comes in. So next slide. So we're really just trying to meet people where they are at. We are thinking that for some people, it's a little bit intimidating to call a hotline. We know this based on the research. They're not ready to call or chat. And so we wanted to find other ways to connect people in suicidal crisis with others. And we based a lot of this on the Stanley and Brown safety plan, right? We know that it's important to connect with other people. So next slide. So for the coping module, we launched this in May of this year. It's a series of, and I'm sorry, it doesn't seem to be showing up. It's a series of 4 pre-written text messages, and it appears right below the hotline. So we did not get rid of the hotline. We want people to call or chat or text the hotline, but if they're not ready, this is an alternative for them. So it's a series of 4 pre-written text messages that people can copy and paste and send to someone to let them know that they are in crisis. We partnered with the International Association for Suicide Prevention, and they really developed the content in collaboration with research and clinical experts, and also with people with lived experience. I should mention that this feature is in its early stages, so we're really kind of testing it out, seeing how effective it is, whether it works, what the impact is, and then we'll move forward from there. So next slide. So Rory's going to talk a little bit about kind of what we learned in this process of developing this intervention.
Brilliant. Thanks, Renee. And yeah, I think as Renee said, this is an ongoing process, is that we're still learning, and that is launched in May, and there's ongoing work to continue to evaluate it. But if I wanted to say a few words about the partnership which led to the development of the key messages. And I'll just give you, because that slide we couldn't see a key message. I'll just read you an example of one of the key messages. This is a reach out message. And the message reads, "When you get a chance, can you contact me? I feel really alone and suicidal and could use some support." So that's just giving an example of one of the messages which the individuals then can cut and paste and text and either send to a friend or somebody else, or to a hotline if they're not ready to reach out to a friend. And so when we were developing these messages, front and center, we had a couple of key principles in mind. First of all, we wanted to, everything that we did or developed was co-developed with people with lived experience. So we worked very closely with academics, with clinicians, but also we convened a group of individuals with lived experience of suicidal thoughts and suicidal behaviors, and asking them what they would find as helpful messages if they came across this module, if they were searching on Google. So that's probably the single most important point, is that collaboration, that co-development, that co-production approach. But in terms of some of the early learnings, what was very clear from those discussions, not just in terms of the people with lived experience and our clinical colleagues, but also we're trying, certainly when I was thinking about this work, I was thinking about the research that me and others have been involved in the context of trying to understand the mind of somebody who's in a suicidal crisis. And I've done a lot of work on the psychology of suicide. And the work that we and others have done suggests that obviously what's key driver to the emergence of suicidal thinking is this sense of being trapped by mental pain. And it's that entrapment that we're all trying to tackle, hopefully to try and de-escalate the sense of entrapment, and certainly reduce the likelihood that somebody acts on those thoughts of entrapment, which become often suicidal, act on those thoughts and translate those thoughts into suicidal behavior in some shape or form. So to our mind, then, we were thinking about the messages together with the considerations of our lived experience colleagues. The key question for me was, those messages must be trying in some way to attack, in some way, hopefully minimize or tackle that entrapment, or certainly at the very least, open up opportunities and not create any further barriers. So if we think about the key messages, one of the key messages is, yeah, as I said already, we want to reach out. But one of the challenges is often people who are suicidal, we know, maybe don't have somebody they can reach out to. And so that was a key message that came out of the lived experience offerings was that whatever we do, make sure we give options, because we know in the mind of the suicidal individual, it's this cognitive constriction, this tunnel vision. And actually, if you're saying, well, actually, I already feel alone, but then you're saying, well, actually, try and reach out to a friend. Well, what do you do if you can't? And so that's why we're keen that it's on the messages we highlight, but actually you can use this message. If you haven't got a friend to reach out to, but maybe to a helpline, it gives you that form of words. It facilitates the help seeking. And then the other sort of couple of key messages were that language matters. That first point on that slide is that be direct, talk about, use the term suicidal or wanting to die. Because again, we know from all the research evidence out there, being direct is really, really important. And as long as we communicate with each other in a sensitive and compassionate way, we're going to hopefully promote communication, promote help seeking, but also tackle destigmatization. And then the second point on that slide on the early learnings is that not everyone is feeling the same way. And that, again, was something we grappled with early on in the process when we were thinking about this, because we don't know what search terms are being used, how the module has been arrived at. And we know that although we're focused on that, as Renee said, at the people in crisis, but we don't know people will have a whole range of different manifestations of suicidal crisis. And we also know from clinical and research experience is that suicidal thoughts wax and wane. They come and go and then change in very short periods of time. So we wanted to make sure we had a range of messages which try to cater for that breadth and the heterogeneity and the diversity of suicidal thinking. And then the third point, I've mentioned already, but some people may not have anyone to reach out to. And it's really important that we don't add further stigma or make people feel more alone and less connected. We're trying to promote connection. And again, as one of the previous slides highlighted earlier today, this morning. And then that last point on this slide is that I've made this point already. It's absolutely crucial that everything we do in crisis and how we respond to people in crisis, how we develop services, it has to be co-produced and designed with people with a whole range of lived experiences. And then just last thing, and then I'll hand back to Renee, is that, as I said at the outset, and Renee has also said, that this is only part of the process. And we're continuing to work with Google in the next steps and trying to hopefully interview people who are using the module to see what does it feel like to use the module? What does it impact on you? Was it helpful? What can we do in terms of its look, its design, and its functionality? And I know we're also working with colleagues looking at different languages in other parts of the world. And I think we're currently looking at our first next step will be looking at Hindi and Indian English. And that consultation work on that is happening imminently. I think it's next week. So with that was my brief overview. Back to you, Renee.
Thanks, Rory. Yeah, so I'm just trying to keep up with some of the comments in the chat. As Rory said, we are looking at collecting data right now to better understand the impact of this module. It's so new. I don't think anybody has launched a feature like this previously. And so we really want to understand what it's doing, whether it's helpful. And then, if it's something that seems to be effective, expand it to other languages and locales. So next slide. So Rory talked about some of the initial learnings as we were building this feature out. We've also continued to meet with lived experience experts, and even after launching the feature, and have gathered some additional learnings that I just wanted to mention. One is that the text messages are a little bit long. And one of the things that the lived experience panel suggested to us is that we might think about shortening some of the messages, that for somebody, as Rory alluded to, for somebody in crisis, it can be difficult to cognitively process all of that information and read a lot of information. And so think about keeping it brief. They also really emphasize the importance of using sort of simple language, the way that we talk to each other, not using medical jargon, but also really communicating the way that people talk or text with one another. There was some discussion around the word trust. So we've kind of gone back and forth. Right now it says connect with people you trust. we've also talked about, should we use the word care instead? Different concerns come up with both of those words. So we're thinking about that. And then helping people to feel cared about is key. I think this is not rocket science. We know this. People, all of us want to feel cared about, and certainly somebody in crisis wants to feel cared about. And so anything that we can do to help people to feel that we are empathizing with them and validating them is really key. So Brian, we'll turn it back to you. Thank you for this opportunity to talk about the coping module.
No, thank you. Thank you both for phenomenal. I'm sitting here as a kind of a grandfather, just picking up so many different things. And before we even get into the other discussion, there was a couple of questions that just kind of popped up. One was in the chat box that asked about whether or not you offer this service in Spanish. And it was a kind of a two-part question the way I read it. One was, if you do, was also taking a look at the language in it, since language matters. The Spanish term for suicide apparently has negative stigma. Any thoughts on that?
We've only launched in English in the US so far. It's really sort of a test. We want to better understand the impact of this feature before we expand. We did just launch screeners in the US, mental health screeners in Spanish. So people can come to Google and take a PHQ-9 or a GAD-7 in Spanish, but we haven't launched this particular feature yet in Spanish. And absolutely, the word suicide, I think, has a lot of stigma associated with it in many languages and in many cultures. And part of our using the word suicide, it was, as Rory said, intentional. We wanted people to be able to accurately label how they were feeling, but we also wanted to destigmatize that word.
Understood. Thank you, Renee.
Yeah, but can I just add one other thing, Brian? But I think that's a great question from Dean. And I think it highlights the importance that as this work moves forward, that local knowledge, that national knowledge, that cultural knowledge has to be central. That lived experience knowledge is more than just lived experience of suicidality. It's lived experience of suicidality in the cultural context is absolutely vital.
Absolutely. Well, one other question before we go to the roundtable. I was just thinking, again, from the age standpoint, if there's been any data collected from the adolescent population, because I think what we're seeing across the globe is the really high prevalence rates of suicide amongst that particular group. Do you have any data as far as they're accessing Google, since everything they do is based on social media and connections?
We don't at the moment. We're in the process of collecting data. This is sort of a broadly targeted feature at this point. It's not specific for youth, but I think as we move forward with thinking about how we can supplement the 988 crisis number, we will want to think about what works specifically for younger populations.
Well, thank you. Thank you so much. And I didn't want to take up all the time from the roundtable because we have two wonderful roundtable discussants that I'd like to bring in at this point. First is Dr. Allison Rourke. Thank you for joining us and thank you for being a part of the roundtable discussion. And the other is Professor Thomas Niederkrotenthaler, who's also going to be working with us on the roundtable discussion. So I'll turn it over first to Dr. Rourke.
Thank you. Just to say, I think this is all like wonderful work, and I'm super excited by a lot of this because my area of research in clinical acumen is really focused on environmental interventions and helping people get connected. So I think that that's outstanding. And I think anything we can do to reduce friction between somebody struggling and getting the help that they need is always a desirable outcome. So just think it's awesome work. And I also particularly appreciate the science lived experience partnership, because I think that is so critical for all of this and the field of psychology in general, but in this particular area. I am like, one of the things that jumped out at me, and I was happy to hear the question about adolescence, is I was thinking about how do we help people identify people who are going to be caring and respond in this empathetic way, because I think, to your point, the words trust and care are challenging, and they might not actually lead somebody to somebody who's going to respond without judgment, who's going to say, like, what do you need? How can I help? Instead of immediately like shifting to like panicked problem solving, which I think often actually makes the situation worse. And I think with adolescents, it becomes an extra nuanced thing, because often who they want to send these messages to are their peers, right? Who are not necessarily in a position to provide the most effective support beyond just scared caregiving. So I do think like shifting to that, like some attention to that, is something I would love to see some additional research on. I'm excited for you guys to be doing that. And yeah, and that was like the first thing that really jumped out at me, but I don't want to eat all of the time.
Well, thank you, Allison. I really appreciate that information. I'm going to turn it now to Dr. Thomas Niederkrotenthaler. Yeah, did it.
Perfect. Thank you. Well, thanks, Brian. It's so great to be here, and it's really the continuation of a process that has been really insightful and inspiring. And I'd just like to add a few thoughts, a few reflections, and it's probably a bit similar to what Rory has said, but still I think it's just important to highlight those in order to go forward. So first, and it's probably needless to say, but still we have the great opportunity here to work with Google. And it's just great that Google is on board to work for suicide prevention. In our field, we often say that suicide prevention is everyone's business. And this basically means that it's not enough for a handful or even a small army of experts to work for suicide prevention. It's absolutely necessary for us to have collaborations with tech companies serving huge numbers of individuals, with many of them also having suicidal thoughts and feelings. And we know today that most suicidal communication occurs online, and what people find when they Google suicide, what types of messages they get, is very relevant to suicide prevention and potentially also makes a big difference for individual suicidal processes. Second, I'd like to say that has been a really inspiring process to work on these messages together with many colleagues from lived experience, having lived experience of suicidal thoughts and feelings. The National Action Alliance for Suicide Prevention has already highlighted 10 years ago that collaboration with individuals with lived experience is key to shape suicide prevention for the better, to make it more effective. The main reason here is that personal experiences open up doors to better understand how people express suicidal thoughts. These experiences also help to better understand what kinds of needs there are in a suicidal process. And further, the number of individuals affected by suicide and suicidal ideation is obviously huge, and their experiences are very diverse, which makes it even more important to get their views for the development of safe and efficient messaging. So the process so far has achieved quite a bit, as we've heard. And in the worst case, I would say we are done now. And I'm really glad to hear that there will be a continuation to this process. And in the best case, it is really the start of something that will help to create a genuine supportive structure on Google to help suicidal individuals and their peers. There are many gaps in knowledge that we need to work on at this point to improve further. First, messages have primarily been developed for users at high risk for suicide with potentially imminent risk of suicide. But we need to better understand the users, their vulnerabilities and risk levels. We need to understand the intentions behind Googling suicide, what the urgency is behind specific queries. Only if we understand this better, it will be possible to provide tailored messages to the suicidal users. We need research, both qualitative and quantitative, to do so. And I need to say that there is a huge gap right now between what we know and what we should know. And so this is a matter of both importance and urgency. And second, we need to tailor messages not only with regard to risk status and vulnerability, but also with regard to, for example, age groups and genders. Also, individuals at older age are nowadays using Google, and they will likely express their suicidal thoughts in different ways from younger users. We know very little about that at this point. And speaking about diversity, it is a well-known fact that expressions of suicidality also differ widely between cultures. For a global leader like Google, it is essential to test messages in various languages and cultural settings in order to make sure they are efficient and resonate well with diverse user groups. And let me end with saying another point about the needs of users. In the process, we have also briefly discussed how users receiving the messages might feel about them. And the major concern here is that with some types of messages, like, for example, I don't know how to live, some users might feel overwhelmed and maybe less inclined to respond here. And so it is very important to do research to see what the receivers of the message need to provide tailored resources which are not overwhelmingly complicated, but still detailed enough to be helpful. And again, only with thorough research, including qualitative and quantitative research, it will be possible to truly provide users with what they need to feel competent and safe if they receive a message asking for help. So Google, it's great. Renee, it's great to have this collaboration, and I hope that we see it moving forward. Thank you.
Well, Professor Thomas and Allison, I just want to thank you both for your invaluable input into this. And I also want to thank Dr. Schneider and Dr. O'Connor for a very timely presentation. I think this is something that is going to spark a lot more talk and a lot more interest in going forward as to how we measure things. So thank you all for invaluable input. And we're going to move ahead in our schedule now. We're going to go over to our SAMHSA updates. And we're asking at this time, Dr. McKeon, if you'll come on, sir.
Thank you very much, Brian. It was fascinating to hear of the work going on between Google and the International Association for Suicide Prevention, and we'll certainly look forward to what can be learned from that. And I would emphasize that, you know, there's an extremely important aspect of international collaboration where we can learn from each other what is happening in one country and can very much help what's going on in another country. And just as an example, 988 started in the United States, and later this year it will become operational in Canada. But there are numerous other examples. So for that reason, I've always valued my membership in the International Association for Suicide Prevention. And if you're not aware, they will be having in September a next meeting in Piran, Slovenia. So it's a tremendous place to learn about suicide prevention. Also on the theme of international work, I would just mention that SAMHSA has been engaged over a period of many years with the International Initiative for Mental Health Leadership. And they will be having its first really in-person meeting since the beginning of COVID next year in the Netherlands. And on the back end of that, if I understand correctly, there will be the first in-person crisis jam. So these international learnings are just vitally important. In terms of SAMHSA's 988 office activities very specifically, the main thing I would just like to underscore is that in the upcoming month, in September, the awards will be going out for the state 988 awards, the state and territory 988 awards, the tribal 988 awards, as well as the Crisis Center follow-up grants. And of course, follow-up is a hugely important to be aware of for all of our crisis efforts. You know, someone's risk doesn't end because the mobile team leaves or because somebody is discharged from an emergency room or even from an inpatient unit. So the importance of the follow-up and connection can't be overestimated. So thank you very much, Brian, for the opportunity to give the SAMHSA update.
And thank you, Dr. McKeon, as usual, for your wonderful report and for all of the things that SAMHSA does in support of continuing this very important measures as we go forward. So thank you again. We're going to move now to the NASPID update, and today we have our Chief of Staff of NASPID, Megan Houck. And Megan, go right ahead.
Thank you, Brian, and you are just doing such a great job. These presentations have been so powerful. You know, thank you for all the work of Google and IASP. I wanted to talk about a learning opportunity coming up at the National Dialogues on Behavioral Health 64th Conference that's happening in New Orleans, Louisiana. It is taking place October 29th through November 1st. And it really, the theme of the conference is dialogues to action, responses to address trauma and violence. It is going to be a great conference. The National Dialogues is one of the oldest conferences related to mental health in the country. And it's really designed to have presentation, but extended dialogue. So the sessions are longer and more in depth. And it's actually intended to be more of an intimate setting. Certainly it's 100 people, but the idea being, concentrating on that dialogue. And this subject matter is just so relevant right now and dispelling myths related to violence and causes of violence and how to prevent violence. So we hope you can join us. I'm gonna put the information in the chat and the link to the National Dialogues website where folks can register and find out more information. So thank you.
Well, thank you, Megan. And as she has pointed out, she's already placed it in the chat box. So please refer to it for your reference. Thanks, Megan, for all you do. And moving forward, we're now going to Medicaid Front and Center. And I'm going to call on Tom Becklock to come forward first and take it away, Tom.
Thanks, Brian. Thanks for doing a great job hosting today. Once a month, we highlight different states in terms of how they're coming along and supporting and developing crisis systems within their states. We've heard from several states, but excited today to hear from Connecticut about their efforts to expand access for children's crisis services. They recently announced some significant expansions in that system. And so I'd like to hear from Mata Williams in terms of everything that's going on in Connecticut and how Medicaid is supporting crisis expansion in your wonderful state.
Thank you, Tom. Good afternoon, everyone. And it's been just, I'm fascinated with all the work that you're doing. Such excellent information about a very important topic. So I'll just give you a quick high level of how in Connecticut, we're partnering with our sister agency, the Department of Children and Families, where they stood up 4 urgent crisis centers during COVID using ARPA funds, and those will be running out soon. So Connecticut Medicaid, that's who I work for. I am a director who oversees most of the major contracts for our health services delivery. So we are now trying to find ways to sustain these centers and continue to promote access to crisis services. So the good thing with us is that the 4 facilities are already enrolled in our Medicaid program. They're part of our Connecticut Medical Assistance Program network. So right now they're licensed as outpatient providers and they're able to bill for evaluation services from a non-medical as well as a medical professional. They're able to bill for individual and group therapy. They're able to use some evaluation and management codes as well as case management codes. However, the billable times are limited. So we need additional services, and that's what we're working to add right now is a triage assessment that will be done by a nurse, and then a comprehensive nurse assessment, as well as some crisis codes. And then our plan is to expand the case management codes that already exist so we can reimburse providers appropriately. We are looking into creating new provider types and specialties where we can just clump the urgent care, the urgent crisis centers. And we will have to amend our state plan as always, which is a process in itself. So this will take us up to about April of next year. Our plan is to maintain our fee-for-service rate methodology at the moment and just have the providers bill as they may. So this is what I have for now, and I don't want to go into all the other little details that we're trying to work through. And at some point when we're up and running, if I have another opportunity, I'll be happy to provide an update. But again, thank you for inviting me, and I'm just fascinated by the work that you all are doing.
Thank you so much. And I think your highlight and your summary provides a lot of the details that Medicaid programs need to be thinking about as we support crisis systems. How are they registered as providers? How do we pay them? What are the rates associated with that? And all of the states are sort of working through this. There's more and more information that can be shared amongst states as states are going through this journey. I'm curious, in terms of the facilities, you talked about them getting stood up during COVID. Do you have a sense of what percentage of the population are Medicaid patients or members that are being served in those facilities versus non-Medicaid?
That's a great question, because that was something that came up. We did say, as Medicaid is moving towards trying, ensuring sustainability of the facilities, they do have, commercial patients as well. But I think based on what they said, Medicaid is about 20% of their, of their patient population.
Yeah, and it varies significantly, I think, from state to state, because it's also based on sort of the percent of the population covered by Medicaid. But I know that's a challenging part of the system design for states as well, is Medicaid can be a sustainable source, but it's thinking through how do we get commercial payers to the table and other payers as well. And for those that are underinsured, what are the funding sources? And so state government and counties oftentimes have to partner around that. But thank you so much for joining us. Hope to bring you back in the future to get updates of how this is evolving, and really appreciate the emphasis on kids, because I feel like sometimes we forget about having those important conversations in these types of settings. So Brian, back to you.
Well, thank you, Renata and Tom. Thank you both. I think you can look in the chat box and see the numerous responses that this is a topic area that a lot of the states and a lot of folks are very much vested in. So thank you for teasing it out and really bringing out the detail to help them in their questioning. And thanks again, both of you, for responding to the chat questions in the chat box to assist in that information getting out. So thank you both. So we're now going to move into our crisis talk for today. And we have with us Stephanie Hepburn, the editor-in-chief of Crisis Talk, who will then introduce the person that she is working with, Dr. Dennis Morrison. So Stephanie.
Thank you, Dr. Sims. Yeah, so I'd like to welcome Dr. Dennis Morrison. He's served as the Chief Clinical Officer for NetSmart Technologies and also the CEO of Centerstone Research Institute. Dr. Morrison, can you share a little bit about what's happening in the behavioral health tech space, and also why you prefer to use the term augmented intelligence instead of artificial intelligence?
Well, unless you've been living under a rock, you might have heard the term artificial intelligence recently. And primarily, I think it's safe to say that everybody on this call has used artificial intelligence in some fashion of their lives, whether it be with Siri, Alexa, or you talking to your GPS on in your car. Now we're seeing applications for tools coming into healthcare, and specifically into behavioral healthcare, that are using artificial intelligence to help clinicians do a better job. The American Medical Association recently came out with a position statement stating that any artificial intelligence application that's used in a healthcare environment should be referred to as augmented intelligence, because those applications are really built to serve clinicians to help them make better decisions and not to replace clinical judgment. So that's true in all of healthcare. That's true of all of the providers that I know of in behavioral healthcare that are clinician facing, that are helping clinicians make better decisions.
So with COVID, people were thrust into the into the tech world very quickly, some reluctantly. Do you feel that was a tipping point for some of these innovations?
Partly, but I think the bigger issue, particularly for artificial intelligence, is the confluence of a couple of things. One, it's the speed of processing computing engines, the cheapness of memory, and better and better algorithms to do that would allow us to do artificial intelligence processing. So I think as we've extended the curve of technology and all of these things become faster and cheaper, then that was one of the primary drivers that led us to the point where we could actually do these kinds of significant processing, because they're very data intensive. The algorithms are very sophisticated, and so a slow processor or expensive memory would not allow you to do these things. But both of those things have now come down in price points, and the technology to develop the algorithms which work on what's called large language models, wherein there's huge volumes of information that have to be analyzed, computed, and used to develop an artificial intelligence engine. And for our industry, it's primarily a specific type of machine learning program called natural language processing, NLP. Some of you remember the old days of neuro-linguistic programming. That's not this. This is a different NLP. Natural language processing really is the tool by which behavioral health professionals can use these tools. And because when you think about other parts of healthcare, for us, words are the treatment. And so having a large language model that allows us to use language to interpret what happens, for example, in a psychotherapy session, which is what a lot of these products are doing now, that's a huge lift. More so, I would argue, than say radiology, where you're discriminating between two images, whether one is cancer and one is not. That's pretty discrete in terms of its analytic processes. To discriminate words is very, very difficult and much more sophisticated, in my opinion.
In the article, we also talk about workforce challenges. So I direct the readers to go look at that as well. Thank you so much, Dr. Morrison, for hopping on with me.
You bet. Thanks, Stephanie.
Thank you, Stephanie, and thank you, Dr. Morrison, because this information going forward is ever emerging and ever evolving. So thank you so much for providing that information for us. So let's go on now to the next slide. And these next two slides are times that we set aside for federal and then state updates. And this is just a reminder that we will have some upcoming within the next couple of weeks updates for you to provide. Next slide, please. All right, and we are moving very quickly, and this goes back to Dr. Morrison in terms of discussions about augmented intelligence or AI coming on October the 13th, the first crisis debate, #1, where AI is the future of crisis care, will take place. So mark your calendars, folks. This is going to be a spectacular event, and we just make sure that we're all available to be able to attend to it. So next slide. This is a reminder, coming up next week, episode 143 on the CCBHCs and the 988 continuum. And then following that, next slide, we'll be looking at episode 144. We're wrestling with suicide alone with Stephanie Mitchell-Hughes, and David is also going to be a part of that as well. So we're looking forward, and you can already tell that there's some exciting topics that are coming in the weeks ahead. So we say to each one of you, stay tuned and continue to work with us. because on this Crisis Jam, we are always listening to what you have as far as suggestions or otherwise. Please don't hesitate to get in contact with us. And again, I want to give thanks to all of our wonderful speakers today, and to say to each and every one of you, thank you for coming on this Crisis Jam, and we look forward to connecting with you next week. So everyone have a wonderful day. Bye now.